to describe the network, there's quite a wide afferent field. It's a S1 nociceptor response, and that is important when actually applying pressure to the sole of the foot. But I think it's important to remember that it's a multi-level synergy circuit. So the information comes up from S1, it's distributed from L5 to about S2, and that results in flexion of the hip and the extensor hallucis activation. And it's only in primates, not in all primates, that the toe goes up. In most animals, it's a protective response to draw away from pain. With maturation of the pyramidal tract and myelination of the fibers, that is inhibited, and a spiral superficial reflex takes over, which causes flexion of the toes, almost in the same way that there is the superficial reflex of the abdomen. And of course, with upper motor neuron lesions, the superficial reflexes go away, and there is reestablishment of the extensor response. But because it's a relatively wide network with lots of different components, that means that there are lots of ways to actually test the reflex. We all know the Babinski. When I was a registrar, there were 5 ways to do it. Subsequently, I've seen that there are now up to 11 ways to do the response. And I think it's helpful to have a few of these in your back pocket, because some patients have very sensitive feet. Certainly in some of the communities where I've worked, patients have really, really thick soles and not wearing shoes, and it's not particularly helpful, and they can be an injury to the foot. And the 3 that I think are personally most helpful, certainly the Babinski. I find the Shattuck really helpful because you're getting away from the sole. And if you can reproduce the same sign, I think it gives you a lot more confidence in what you're seeing. And I also like the Gonda-Stransky. And in fact, it's sort of like the Hoffmans of the foot. Obviously, it's a different reflex, but it is really, really helpful. And notice that extra screen moved across in the same way that you're supposed to do the Babinski. Sensitivity and predictive value are really quite similar for the Babinski and Shattuck. It hasn't been looked at if you increase the sensitivity of positive predictive value if you combine them. So if there's any registrar's got lots of time in their hands and wants to go around, I think that would be something that works. But yeah. And of course, not only are there different ways to do the reflex has different qualities and different appearances. So the true Babinski is where you have a full withdrawal. Minimal is when you only see flexion at the tensor fasciolata. And so often, I was picked out as a registrar for only looking at the toe and not looking at the whole leg, which I think is important. There's the pseudo, which is pulling away. There's the cross extensor, which really I think speaks to the distribution of the upper motor neuron signs, where you do it on one side and you actually get the plantar response on the opposite side. There's inversion. I've seen a patient who was in a motor vehicle accident on a motorbike and fractured his foot. And there was a question whether or not he had an upgoing plantar, because every time we examined him, the toe went down, but he had actually lacerated the tendon. And then there is the spontaneous Babinski, and I think that this is a misnomer because it's not spontaneous. What it is when you're stimulating other parts of that network, whether you're doing hip flexion, whether you're doing a cross adductor, a reflex, and the plantar goes up, but there is a stimulation. And I think it's important to think about the spontaneous versus the striatal toe, because the striatal toe is an upgoing toe, and only an upgoing toe without any of the other features of the extensor plantar response. There's no fanning of the toes, and it's without stimulation. I think when you look at the definition, it's supposed to be in the absence of other signs suggesting corticospinal tract issues. I think that becomes really problematic when you're dealing with complex conditions like the atypical Parkinson's disease. But this is seen in dystonic syndromes. It's seen in 10% of Parkinson's patients. It's supposed to be in advanced patients, but I certainly think that if you're seeing it in very early on in the disease, you need to be quite cautious if it's not related to dopamine. It's supposed to be more common in MSA as opposed to PSP, and it's relatively rare in cortical basal degeneration. And it can be seen in stroke, but those strokes are usually quite frontal. And the big differential for the upgoing toe is functional. And I think that this technique is really helpful. So if you see a patient with an upgoing toe and you apply pressure to the nail bed and you elicit pain and you're getting a lot of resistance, that's less likely to be a striatal toe. But for the striatal toe, you can only push back down, and slowly it will come back up. Once you've established that, you can check flexion of the rest of the digits. And if the patient is able to apply force and the toe goes down, it's more in keeping with the psychogenic toe sign, And if the toe remains up, then it's more in keeping with the straighter toe. So those I think are some handy tricks to have in your pocket. And I hope that for registrars, all of you mention it, but I think what's important is what Jan van Geen used to has written, and that's interpreting the plantar response is not whether the great toe goes up or down, but whether an upgoing toe is a pathological response. Thank you.